My name is Eileen Davidson, also known as Chronic Eileen, and with me today for the 23 Talkover campaign is Dr. Ayman Askari. TalkOverRA is a campaign to help those with rheumatoid arthritis improve their communications with their rheumatologist around remission. But that's sometimes an unclear concept for many, myself included, in the early years of my diagnosis. For the TalkOverRA campaign this year, I decided to interview as many rheumatologists from around the world on what remission is for them. After attending the Canadian, American, and European scientific conferences, I really like learning from experts in their field and from around the globe. I hope you learn something from this project you can use in your journey with RA or even other types of inflammatory arthritis, wherever you are in the world. Today, I bring you Dr. Ayman Askari, a consultant rheumatologist I met in 2019 at the American College of Rheumatology Conference in Atlanta, Georgia, and I have seen him every year since at many different conferences, and we've connected many times, and I value his opinion. Dr. Askari, can you please tell us a little bit about your role in rheumatology and where you're from?
Thank you, Eileen. I also admire your work and the support you give to the rheumatology community. We met several times. That's absolutely correct, and enjoyed our discussion regarding how to best help patients. I consider myself an experienced rheumatologist. I have been in the UK for at least 30 years working in the field, Scotland, Ireland, England, and I also taught medical students at Keele University, rheumatic module. Currently, I am the lead clinician in my hospital, which is Robert Jones and Agnes Hunt. It's one of the top hospitals in the north of England. I run a clinic every day at least. So I would say I see about 200 patients a month, but not only rheumatoid. This is the spectrum of all inflammatory arthritis and many cases of fibromyalgia, fatigue, osteoporosis, related diseases, related conditions to rheumatic disorders. So that's in summary really what I do. Obviously, I have a lot of admin commitments. Being the lead, I have admin commitments with meetings, with devising new protocols, infusion unit for our patients, management decision, and so on.
Yeah, and that means you are a very good person for this interview. So I'm going to dive in. I've got about 13 questions for you.
Dear.
Can answer them all or not. Obviously, if the ones that cannot be answered are areas where research should be done. Now, being that you are not from Canada or the US, and how much the American guidelines and the Canadian guidelines are similar, I would like to ask you, how are the clinical guidelines for remission for rheumatoid arthritis different or the same between the UK and North America, if you've noticed anything?
Well, I think the guidelines on the whole are really, in a way, resemble each other. Their aim is to be safe for patients. And it's very really right and accurate that they are updated every few years. I don't see much difference really in our approach to medical treatment. Probably we use steroids more in Europe and in the UK as a bridging procedure to get patients into remission, while probably it is more or less used or more frowned upon in the US. So that's one observation, and it varies from clinician to clinician. The other is, I would say, probably the use of biologic is more rapid in the US. We would like to use 2 DMARDs, and we have to show that the patients have failed or showed inadequate response to two DMARDs prior to the use of biologics. Having said that, I must say that the prevalence of biologics now, the availability, the low cost of many biologics have encouraged us to really quite rapidly to move into biologic therapy.
Mm-hmm. Wow. I have so many more questions I could ask you after that, but my next question will be, what is remission, and is there a one-size-fits-all for remission?
Well, I mean, there are criteria for remission, which is also published by the BSR, ACR, and EULAR. The remission is for me, is that the patient has no active disease, no progression. He is functional. He's able to do his job. And also we rely sometimes on biochemistry. So we see low ESR and low CRP. Achieving remission is always at the expense of side effects, because if we want to use full doses or combination, possibly the patient have more side effects to achieve his remission. So sometimes we have to accept that patients are in low disease activity or low remission state, but at the same time without major or disabling side effects. I hope that's clear, really.
That was very clear. That is actually quite common to what I've been hearing from the other perspectives that I've asked. Now I'm going to ask you, how long does remission typically last, and what causes someone to fall out of remission if they are there?
This is also very variable. You see, we are human beings, so each person has different the different perspective of his disease and different experience, and I can talk about my experience and on the whole. Usually most anti-rheumatic medications last probably 3 to 5 years, and after that they are no longer effective. This is called tachyphylaxis. It's a phenomenon known in medicine that medications lose their efficacy after 5 years, 6 years. Having said that, again, I have seen many patients who had anti-TNF therapy or etanercept who have been on it now for 10 years without any blebs or flare-ups. So that's good. It's if you ask me your next question, which would be very intelligent, how do you predict? I would say no, I cannot predict who is going to have long-term remission and who is going to be unresponsive in a few years. We know that having anti-CCP positive and having high disease activity markers make patients more likely to flare up in the future, or they are having more severe disease. And we probably know that's an answer to your second question, that infection, stress might cause what you are calling lack of remission, or what I would call a flare-up in disease activity.
Can you have a flare-up and be in remission?
That is really contradictory. So, but what I think what you mean is that you are in remission, but you have a flare-up during remission. Mm-hmm. That's what I'm describing. So if you have an infection, let's say viral infection, COVID as an example, that may cause a flare-up of your joint pain, an increase in the inflammatory marker, and then that could be treated with or managed, and then you go back into remission. Mm. So that's possible, and that's what we see in our routine regular clinics and monitoring patients.
That's really good to know. Now, can somebody still have pain, fatigue, or cognitive dysfunction while in remission, and not necessarily a flare, but just lingering symptoms that just won't go away.
Absolutely, and that is really a bulk of my practice, and that's something I want to alert other junior rheumatologists and physicians to, that pain, fatigue, brain fog are not always necessarily related to a flare-up or a state of unremission in rheumatoid arthritis or lupus. So one has to rule out other causes which are related to flare, to fatigue and fibro features. So patients complain of generalized pain, tiredness, exhaustion, fatigue, brain fog, maybe sometimes irritable bowel syndrome, sensitivity, sort of the spectrum of fibromyalgia, fatigue, and that's not necessarily related to rheumatoid. So they need investigations, full investigations, and ruling out causes of their fibrochronic fatigue, other causes. So this is probably non-structural, so what we call a non-structural or non-inflammatory pains. And this should be treated separately, really, in a different methodology or different approach. And the mistake which happens frequently is that anti-rheumatics are increased, or let's say, methotrexate is increased, or the biologic is changed. And usually, at least in my experience, there are other causes. It could be viral infections, COVID again. It could be stress. It could be social issues affecting the individual at that time.
Mm-hmm. Now, you've sort of touched base on this with your previous answer, but what are some of the comorbidities that get in the way of somebody achieving remission?
You mean why people do not achieve remission?
Yeah.
Well, first of all, they could be not responsive to my choice of medication, and that is documented. Some patients, not many, thankfully, do not respond to a certain medication, and that's we know the number of responders are about 60 to 70%. So we are left with 30% of patients do not respond to one agent, but they may well respond to the second agent. So that's one important cause of not achieving remission. You know that there is a lack of compliance, and that is being documented. And I am really sorry to say that many patients do not take or do not adhere to medications, particularly when they cause some side effects. I've seen it a lot in methotrexate therapy. So that's I gave you two main reasons why not achieving remissions. If there is concomitant disease, let's say diabetes causing peripheral neuropathy, for example. So we are under the impression that the pain is due to rheumatoid, while in reality the pain is due to another illness. Like diabetes, like Parkinson, other illness which is happen to be concomitant with inflammatory arthritis.
Okay, and my next question is, can you stop medication if you reach remission?
Well, there are many studies about tapering and reducing, and there is in Bristol recently there have been publications regarding that we can reduce biologics by 30%. So if you are taking let's say an example, an injection every week, so we can make it every 10 days and reduce it further and so on. So that's at the same time observing blood tests and observing clinical response. We measure the DAS score, and the ACR response rate, so tender joints, swollen joints. So we can manage that. And the patient themselves actually know. They tell you that, look, I used to take this injection once a week. Now you made it once every twice a month, or we say in England fortnightly, and it's not working. I feel I'm going into a flare. I am more stiff. So you would know from clinical examination, from talking to the patient, and from blood tests and then I think you should really go back to the original regimen of therapy and stop tapering. But in general, as a general rule, if patients are in remission for 2 years, and in some practice, some countries say 1 year, you should consider reducing or tapering therapy.
Wow, that is nobody's actually gone over that with me yet, so thank you.
Yeah,
So much.
I would say that if somebody in remission for 2 years, my practice is to try and consider tapering or reducing biologic therapy.
Interesting. Here's a question for you. Are remission rates increasing, and why or why not?
Remission rate are increasing, and that's a personal observation. And I think the reason is we have an armament of so many medications available now, and they are all effective. We have the anti-TNF therapies, the anti-IL-6 group of medications, the rituximab. We have the JAK inhibitors, and that's, let alone the DMARDs, which control at least 40 to 50% of patients with rheumatoid. So remission rate is increasing. The face of rheumatoid and its complication is reducing. So that is good news. We had a little bit of flare-ups with COVID, I must say, but now, thank goodness, we are winning against this epidemic.
That is great news. Yes. All right. So I had 3 more questions before I let you go. Thank you so much for so much information you provided so far. I could definitely interview you again with many questions, but in the interest of time, I just got 3 more for you. My first one would be, does lifestyle play a role in remission?
That's a very good question, actually, because patients help themselves. So it's not only us. And that's one of the reasons why I see you, and I'd like to collaborate or discuss with organizations that similar to what you are leading. We have in the UK also supportive organizations for rheumatoid patients. So patients who have remains smoking, I'm afraid they will have so lack of adherence if they don't take the medications and they smoke. I would say these are two important factors for not achieving remission.
Okay, so here's one that I think is important to a lot of people who have been living with rheumatoid arthritis for a while and aren't just newly diagnosed. But as we have known because of the research, early and effective treatment is important for those with RA. However, for many patients, it takes time to find the right medications for us. For those that it can take years to, can we still reach remission? And are there any populations more likely to achieve remission than other populations in the world?
So are you saying, are there people who are more responsive to
Yeah.
certain medications than others?
Yeah. So the question would be, the people that have been living with RA for 10, 15, 20 years that have had, a fair amount of damage done by the disease, with the new medications and everything coming out, and research we're doing around like integrative approaches and lifestyle changes and things, can somebody who has been dealing with rheumatoid arthritis for a long time, maybe the more severe to moderate type, still achieve remission?
I think I will have to be very guarded answering this. Uh, Seeing so many rheumatoid cases, I think the more medications the patients with rheumatoid try. So let's say a patient who had all the DMARDs and then couldn't continue for side effect reasons or didn't respond. And then we moved to biologic therapy, and we tried the biologic therapy. And also he or she developed side effects or did not fully respond. I think their chance or probability of achieving full remission will be less than a person who is first exposed to his first biologic. I cannot show documentation or papers on this, but I would say that from my experience, that the more medication you use for rheumatoid arthritis and they cause inadequate response or side effects, the less likely that we will find an agent which will cause full remission, will achieve full remission. I don't want to be pessimistic. It will happen, and the more we look, probably the more we will find. But that is really what I have observed so far. It's possible the body becomes unresponsive, or the immune system get used to various agents and fight back. I am not sure. I cannot I cannot really comment scientifically on this.
It's still very interesting. What about any populations that you see achieve remission or don't achieve remission? Say, this could be sex, this could be race, this could be seropositive or seronegativity preference, or anything else like that.
Well, I mean, this is also epidemiological work, epidemiological research. I would say patients who are seropositive for anti-CCP and rheumatoid, and younger patients are more difficult to achieve remission, and probably they will have a more active disease and may take more agents to control their illness. That is my preliminary approach. Now, whether you are asking whether the Chinese race or the black race have more rheumatoid or less controllable rheumatoid, I'm not sure. I cannot comment. I'm sorry.
That's okay. I like to ask questions that stump people.
Yes.
All right. So I only have one more question for you. And thank you so much today for chatting with me. You answered a lot of questions differently than the other previous interviews, and mentioned things that I would have many questions about still. So I really appreciate you taking this time. Obviously, we need to connect some more. But I think given that you have such great experience with rheumatic disease patients, this is an important question for you. What are some important questions patients can ask their rheumatologist around remission? And is there anything else that you feel is important for patients to know?
I want to thank you for giving me this opportunity to express some views. And the whole idea is to help patients, really. And your work is invaluable in education. I always believed in education. Now, second part of questions, I think patients should avoid cold, damp, humid weather. So they probably should all move to south of Spain, but that's by the by, and avoid infections. So I think COVID didn't do us a good favor, but any infections, flu, bacterial infections can cause remission by the infective process itself, or by the fact that when you have infection, you need to stop your medications because they are no longer, you will not get better from the infection unless you stop the immune suppression. So that's also will cause a flare or will cause so if you are able to avoid infections and bacterial, viral, and adhere to the medication, that's the best guarantee that you are less likely to get remission, to get sorry, to get a flare up.
Thank you. Wow, that was a fantastic answer. And again, thank you so much for taking the time to answer these questions. I know I will have to do a follow-up with you sometime in the future. Any last words?
Thank you, Eileen. I look forward to chatting with you again.